things he's done now is quantitative gene expression based on RNA sequencing. And for example, if we're trying to cultivate an immune response against the cancer, the tumor has intrinsic immune evasion mechanisms. And we can actually identify which mechanisms are upregulated in a particular cancer. But we can look really across the entire biology and see, what's going on with each individual's cancer. And it turns out that one brain tumor is not like another. And even though they look similarly under the microscope, when we start doing this in-depth molecular diagnosis, we find quite a bit of heterogeneity. And this IDH mutation you have results in gene silencing. And one of the genes that gets silenced is a DNA repair checkpoint called ATR. And ATR forces the cell cycle to pause in order for DNA repair to occur. And so when it's another kind of break, and when the brakes are off, the cell is dividing before it is ready to. And so as a result, you get genomic instability and this chromosomal instability I was talking about. And over time, this tends to get worse every time the cell divides. And so quite often when we do multiple biopsies of cancer, we see the same mutations, we don't see any new mutations, but the chromosomal aberration becomes more pronounced. And in the survival of the fittest way of selecting cells, any change in the cancer that fortifies it and gives it a growth advantage is selected in the Darwinian sense, survival of the fittest. Sometimes there are changes, chromosomal changes that diminish the survivability of the tumor. Those cells die out. But the ones that are selected tend to be the most aggressive and most, the ones that can cause disease resistance and so forth. And so one of the things that we see over time is the evolution of AA into GBM, anaplastic astrocytoma to glioblastoma. One of the areas of concern is if you read the fine print of the pathology report, the pathologist talks about giant cells, and he was concerned about the transformation of giant cell glioblastoma. And so, it's you've done really well in spite of that, and really well in spite of having a high Ki-67. But there is the sense that we may be sitting on the verge of a change with this last MRI. And I think your next MRI, I would order spectroscopy and perfusion, just in case it's still a very subtle change. When we look at spectroscopy, we can often make a diagnosis. One thing versus another, post-operative change versus tumor that's coming back.
And is that, as far as on the radiology testing side, the higher tonnage magnet that I would need to come down to LA for, or is that something different?
Actually, the magnets that you've been having are pre-tested magnets. So you have really, nice equipment up there. But essentially, the spectroscopy is a software package that is phenomenally expensive and usually not purchased by most institutions unless they have enough volume to justify the purchase. And so that would be worth a trip to LA for. Okay. And we don't even have it in Beverly Hills, but for example, the Angeles Clinic has state-of-the-art MRI scanners, spectroscopy, perfusion, and a really decent radiologist also. So I would vote for doing the next scan at that facility.
Okay, well, I have my next scan coming up here at the beginning of May, and it's scheduled here in Santa Barbara.
Right, that's what I'm saying. I would think it might be better to do it with spectroscopy.
Okay.
Because, just to evaluate this change a little more now, I have another patient I was just dealing with last week with the same kind of issue. And he had his spectroscopy, and it was all treatment effect. So it's gotten him out of having to do anything else at the moment. And, I hope that maybe you'll have a prolonged opportunity not to have that disease treated. But eventually, one would expect that this will come back.
Right.
And I think that one of the things that I would tell you, if you don't already know it from your other consultations, is that IDH1 mutated tumors are the most responsive brain tumors we have.
Right. They respond well to treatment.
Right. A much bigger benefit.
Yeah.
And the reason why is because the IDH1 causes the silencing of MGMT, which is a DNA repair enzyme. And when MGMT is high in the cell, it tends to repair the damage that's caused by temozolomide radiation very efficiently. And when it's silenced by IDH1, then you see this huge benefit, survival benefit from getting treated. And in fact, one of the things that's missing in your evaluation is its MGMT methylation score.
Okay.
And so, in a sense, some people say, it's academic, it's going to be methylated because it's IDH1 mutated. But it turns out that the degree of methylation is linearly correlated with the magnitude of benefit. So the higher the methylation score, the more benefit and the longer you live. And the lower the methylation score, then maybe we should think about really trying to do other things as well to, tweak the treatment to be more active. So, so I think it would be worth knowing that, just to kind of, give us a better sense. Do you have a super responding disease, or do you have more,
Would that be an additional molecular study with like more slides cut from the tissue sample?
Yes.
Okay.
Right. And so that's also true of the chromosome microarray that I'm proposing. And if you decide to have RNA sequencing done, that would be another sequencing thing too. So they would go back to the original tumor and take some more slices off to get those things done.
Right. Yeah, I think, there's a decent amount of material there, but it is a finite quantity, but I think there's plenty.
Yeah, there's a pretty big tumor. So I think it's likely. Now, another thing that's kind of interesting is this whole IDH1 mutation business.
Right.
The way it causes gene silencing is through this chemical reaction called methylation. And normally, methylation and demethylation are balanced chemical reactions inside the nucleus. And the demethylase enzymes, there's a whole slew of them. The one that's typically affected by IDH1 is called TET2. And essentially, TET2 is poisoned by this oncometabolite called 2-hydroxyglutarate. And but it turns out that it's not completely knocked out. And one of the interesting things we've discovered recently is that TET2 is vitamin C dependent. And when we're giving so-called hypomethylating drugs to patients with diseases that are caused by methylation. If we add vitamin C, like ordinary doses of vitamin C, then you can double the effectiveness of those medicines. And I'm talking like 250 milligrams once or twice a day, not high dose or something like that. It turns out that about 7% of the population is frankly vitamin C deficient. And probably twice as many people have very borderline vitamin C levels. And so it kind of depends on your diet. And since I discovered this, I started measuring vitamin C in my own practice here, and I find quite a few people who have low vitamin C levels. So you don't have to spend the money on that if you don't want to. You can just start taking 250 milligrams a day. Then there's the high-dose vitamin C, which is been in the alternative medicine world for quite a long time. Recently, they performed a randomized trial in glioblastoma patients who, after surgery, went on and got radiation chemotherapy. They were randomized to get 1.2 grams per kilogram of vitamin C intravenously 3 times a week or not. And there was a major survival advantage for people who received high-dose vitamin C, which is leading to a more definitive kind of trial. And I don't know that you have to do that. It seems the benefit was larger in the unmethylated patients who had a poor prognosis, but there was a survival advantage in the methylated patients as well. It's usually you have to pay cash for this. It's generally about $250, and they did it 3 times a week. It also takes 4 hours to get it, and so it's rather tedious to sit around getting an infusion for 4 hours. But I think it is worth mentioning simply because it's really pretty non-toxic. And there is one thing we need to check if you're interested in this, and that is whether you have G6PD deficiency, which is something you're born with that makes your red blood cells sensitive to oxidation. So if you have that deficiency, which is maybe 1 or 2% of the population, there are certain drugs you cannot get, including high-dose.
Got it.
So I know you were interested in IDH1 blocking drugs.
Yes.
Ivosidenib. There's a new one that's out called HE881 or vorasidenib from the same company.
Okay.
And it's in clinical trials in LA and UCLA. If you go into a trial, you have to qualify for it.
Right.
And normally that means you already have the standard therapy and now you've relapsed. And so I'm not sure you would qualify for that trial.
Right.
I said that I can prescribe it for you, but it's unlikely to be covered by your insurance company.
Right. Yeah, that was what we did the first time around with the what's it called? The inhibitor. It was written a prescription off label, and then the insurance company denied it, and then the pharma company came in and covered it, and then I was told not to take it by one of the experts.
Which this was Ivosidenib?
The other one, what's the brand name for it? The first one, not the
Temozolomide?
No, not that. It's it's one of those synonyms. It's I'm just trying to remember what the name that you can pronounce is.
Tipsogo?
Yes.
Yeah, that's the same thing. That's the brand name.
Yeah.
Okay.
Yeah. So I know what you're saying about fighting the insurance company, and I did that. I got a prescription off label. The insurance company denied it, and then the pharma manufacturer said, we're going to go ahead and give it to you?
What was the reason why the other oncologists didn't want to use it?
Well, it's sort of, in the same realm of what you were getting at before about that sort of like braking mechanism. And his opinion was that if you target those cells specifically and they're inherently slow growing because they have that sort of like, check, braking system, that if you remove that, you don't remove the underlying metabolic pressure, and then something else can come in its place and divide rapidly or more rapidly.
Right, that's an interesting argument. There's, actually, we already have clinical trials of this drug in low-grade glioma, like right below anaplastic.
Right, yeah, grade 1, grade 2, yeah.
And, initially I think people were really expecting a nice response, and it hasn't turned out that way. What we see is just kind of stable disease. The tumor just sits there. And the good news is the drug is extremely well tolerated. But I think it's been a disappointment that we're not killing IDH1 mutated cancers when we block IDH1.
Right.
So most of the commentators who write about this say that even though IDH1 causes the cancer initially, whatever happens as the tumor progresses is independent and separate from IDH1. So we don't get to actually kill the cells by giving them. But probably we are slowing them down.
Right.
And I think arguably there is a benefit for taking a non-toxic, easily tolerable
Yes.
drug that puts your disease in some sort of stasis. We didn't see what that other oncologist was worried about, that the tumor became more aggressive.
Right.
So also there's now evidence in the other IDH1 mutated cancers. It's already approved for acute leukemia, but then at the European Cancer Meetings last year in cholangiocarcinoma, they see that ivosidenib has a response rate, and it's actually been fast-tracked by the FDA for this. And then there are now case reports that IDH-mutated chondrosarcoma, which is the treatment of disease response to nothing, also responds to ivosidenib. So I think taking all of this data together,
sure,
leading in the direction of wanting to put it in your strategy somewhere. But since you have this super responsive disease to traditional therapy, you used the word barbaric, and I was thinking about that because a lot of what we do in oncology can be considered barbaric. But it really has to do with the ratio of benefit versus toxicity.
Sure.
And so when the benefit is marginal and the toxicity is significant, the whole concept that that's a therapy, it becomes questionable. But when the benefit is great and there's some toxicity, that's a reasonable therapy for patients. And then it comes out, is there anything we can do to mitigate your risks? And the main risk, I think, is the radiation.
Go ahead.
Main risk is really probably the radiation, which causes scatter. The radiation goes through the tumor.
Yes.
And they adjust the beam so that it summates on the tumor and minimizes the dose of the rest of the brain. But there is a new technology in radiation called proton radiation.
Right, I've heard about that one. I've heard about gamma knife.
And the protons, essentially, they go to the tumor and they don't go through, they stop. So you're depositing all the energy in a specific area. And so we can already get these things paid for in children and for certain diseases. For example, if we're treating the spinal cord, you have to radiate from the back, but you don't want it to go through the front and fry the throat and the thyroid gland and everything else. So you use protons, which just treats the tumor in the spinal cord, and then stops. So there are proton centers around. MD Anderson is probably the busiest of them.
Right.
Over here in Loma Linda, which is just east of LA,
Right.
they have one of the most established proton facilities around. So that is, it's close enough to check it out. And then there's this other imaging technology called FET-PET.
Okay.
And a PET scan is generally a glucose uptake scan using a fluorinated, using a 2-deoxyglucose, which is antimatter labeling glucose. But they're also labeling amino acids. And the Germans and the Europeans for a long time have proven that you can get better imaging of what is the treatment volume you have to treat. So in the US, they just say, okay, we're just going to give a halo around the tumor or around the resection cavity. And you can either overestimate or underestimate the treatment volume by doing that. So I think, I'm not sure why we don't have FET-PET everywhere in the US. I think it's only available in selected places. You might be able to get it at UCLA. Most places who have it are doing it as a research tool, but I think if I was getting my hand, I would want to, get the benefit of that technology. So, there again, it's another way to try and lower the toxicity by not treating things that don't need treatment.
Right.
And so, I think that's something to think about. I'm just kind of looking at my list.
Sure.
So, another interesting thing is that your tumor has 2 Atrix mutations.
Mm-hmm.
So Atrix is involved in something called the alternative lengthening of telomeres. And essentially telomeres are the ends of chromosomes, which every time a cell divides, they get shorter and shorter and shorter. When we get to the end, then there's no more cell division, and the tumor goes into senescence, or the cell goes into senescence. That's a normal mechanism. And so what cancer does is it keeps lengthening the telomere, so that it can divide forever. And we call that replicative immortality. So normally we have a telomerase enzyme, but this Atrix is an alternative way of getting the telomeres lengthened. A less known thing about Atrix is that it's also involved in a group of proteins that defends the cell against viral infection. And so, if you have an Atrix mutation, then the infectivity of viruses in that cell is 10 to 1,000 times greater than a cell that has an intact Atrix. And one of the things that we're interested in is using viruses as therapeutics. And so, for example, in Germany at a place called IOCK, they give a Newcastle disease virus, which is a bird virus that selectively infects cancer cells and leaves normal human cells alone. And actually they administer it intravenously, and the idea is that it infects the tumor cell, and the tumor cell then, while it's producing viruses, triggers an immune response. And so it turns out it's a fairly easy treatment, easy on everything except the wallet, because it's about $5,000 every time you get this treatment. There are other oncoviral therapies that are in development. Actually, one is already on the market using a modified herpes virus in patients with melanoma. We know that it can generate this kind of immunity against the tumor. And there is maybe a breakthrough that's happening in Japan with the herpes virus called G47 Delta. Let me just make sure I have that. I'm going to send you my note at the end of this, but G47 Delta was reported at the neuro-oncology meetings last November in a group of patients who had glioblastoma that came back. And normally, people don't live very long after that occurs, and they had a 92% one-year survival from giving this virus by injection, stereotactic injection. So we go back to the operating room and using these, fancy ways of putting needles exactly where they want. They can deliver the virus right into the tumor and without actually having to open the skull and so forth. And so the Japanese has fast-tracked this for approval, and we hope it'll come to the U.S. very soon. In the U.S., we have poliovirus trials going on in Duke, but I believe you need a diagnosis of glioblastoma. And whether they would take this suggestion in your pathology report in conjunction with, an MRI appearance that enhances, it might be worth asking if you wanted to get, treated with that. But in any case, the whole concept, I think, is this question: can we raise the immune response against a tumor? There are, I would say in the last 7 or 8 years, this has become the fourth pillar of cancer therapy, based on the observation that there are people who normally would have advanced metastatic diseases like melanoma and lung cancer. And when we can raise an immune response against the tumor, patients can not only have a longer life, but complete remissions, and sometimes even cure. And so it's really the holy grail of oncology, is what can we do to overcome the immune evasion mechanisms in the body. And so oncoviral therapy is one of those things. Last week, in a somewhat, it's not really a clinical journal per se, it's Science Translational Medicine, there was an interesting paper on glioblastoma showing that high-dose niacin, which is vitamin B3, can reverse the immunosuppressive tumor microenvironment in glioblastoma. So normally, the cells that are outside the tumor cells are involved in suppressing the immune system. And specifically, there are cells called macrophages, which can either be part of the immune response, or they can quash the immune response. When they are against the immune response, they're called M2 polarized, and when they're for the immune response, they're M1 polarized. And it turns out that these cells, by the way, are circulating in your blood as monocytes. And there's this interesting experiment showing that in people who are diagnosed with high-grade brain tumors, that the monocytes from other people's blood can prevent that tumor from growing. But the monocytes in the patient with the tumor have taken on this immunosuppressive character, and they don't suppress the tumor. Now, evidently, taking high doses of niacin reverses this polarization. And they showed in this laboratory animals injected into glioblastoma that high-dose niacin increases survival. And if you do it with temozolomide chemotherapy, it increases survival a lot more even. And we've been giving high-dose niacin to patients with high cholesterol for many years, for decades. And so there are now even drugs on the market which are time release and other formulations designed to overcome the flushing that comes from high-dose niacin. It's essentially a non-toxic treatment, and it's something I think you could do that, maybe we could do something to reverse this immunosuppression. Question, has that been done in the clinic yet? No, it's not a clinical trial. It's only been done in animals. But the science is so well done that it's extremely attractive. And part of my style as a doctor is to translate those kinds of observations into how I manage patients. Because the way we're doing it in standard therapy is not that good. So anything that might be able to improve what we get, I think is something I would consider. Now, one of those subjects that's been a sort of peripheral subject in oncology has now become a mainstream subject, and that is gut microbiome. Have you heard about this?
Well, not specifically, but I find it hard to believe that it's not related.
So it turns out that the T cells that attack the cancer and kill it have to be educated in the GI tract by the bacteria they encounter. And certain classes of bacteria cause these T cells to express receptors, which allows them to home into the tumor bed. Those are called chemokine receptors. And if you don't have those bacteria in your gut, your T cells will never find the tumor. And this was initially shown in the laboratory in mice that were implanted with melanoma, that were treated with checkpoint inhibitors that takes the brakes off the immune system. And then if you give the mouse an antibiotic, the immunotherapy no longer works. If you replace the bacteria in the gut of the mouse, then the immunotherapy comes back and starts working again. So people started looking at this as a clinic, and they found out that if you divide the responders and the non-responders, that their gut microbiomes are completely different. And so now we're interested in trying to cultivate a microbiome. And you can do this with probiotics. Most probiotics are worthless. I discovered that the hard way. But finally, when we were able to sequence what's in somebody's stool, what bacterial colonies are in there, we found out that taking bifidobacterium bifidus is worthless because there's none in the stool. However, there is a product from Italy called Visbiome 3, which I have very good experience with, and many of my patients who paid for having their stool sequenced every month, they all respond to it. So now they don't even sequence anymore, I just put people on Visbiome. It costs about $80 a month. And if you do it in conjunction with prebiotics, which is a fertilizer, which is methylcellulose, that's what the bacteria like to eat. So if you have a high-fiber diet, fruit, vegetables, salads, you don't need really to worry about it. But if you don't eat that much fiber, you can take some inulin pills, which are cheap and over the counter, and have no side effects at all.
Yeah, what are your thoughts about my other, GI stuff that I brought up relating to the AA?
it occurred to me that you might have a microbiome disturbance. You mean the IBS?
Yeah.
Stuff? Yeah. And so there are many things, you know, if you've ever been treated with antibiotics, that destroys your gut microbiome. Also, the insecticide called Roundup, glyphosate, that they spray on all of our foods,
Right.
that destroys the gut microbiome.
Yep.
And so many people have, you know, this microbiome-related diseases like allergy, inflammation, autoimmune disease, even cardiovascular diseases accelerated by certain bad bacteria. And so if you're a typical American, you know, you could have this problem unless you eat only organic food, never go out to eat. You filter your water because even the rainwater has glyphosate in it. But most of us are getting a pretty good dose and have a suboptimal gut microbiome. So it could be, you know, you might be able to cure your gut by using these probiotics. There's another thing which I think is quite interesting. I had the good fortune to go to the so-called glioblastoma brain tumor summit last November in Boston. And they presented a bunch of interesting ideas and so forth. One of the people who was presenting is a kind of a rebel professor from Boston College or BU, one of those, called Thomas Seyfried, who is really completely against the way we treat cancer in general and wants to treat cancer with metabolomic approaches. And it turns out that the altered metabolism inside of the tumor is something that we can target, but we haven't yet really become very good at targeting those things. There are now some approaches to doing that. So what happens in cancer, in a lot of bad cancers, including IDH1 mutated cancers, is something called glutaminolysis. And so glutamine, which is an amino acid that's a normal component of our body, gets basically kidnapped to supply the tricarboxylic acid cycle with glutamine in order to supply all the carbon that's necessary for a tumor to grow. And if you block glutaminolysis, you can increase the survival because you're basically slowing down the ability of the tumor to grow. Another metabolomic strategy is ketogenic diet. Have you heard about that?
Yeah, I've heard about both. Yeah, the glutamine scavenging therapies, and also the keto diet. Which is also takes a lot of discipline, and if you only do it 6 out of 7 days, it doesn't really work. So I mean that's another hard one, being a typical American.
It's a tough drug to be on.
Yeah.
But what Seyfried showed is that both of these things extend survival. If you do them together in laboratory animals, all the animals survive. None of them die. 100%. And so it appears to be synergistic. And what's interesting is that there is now a drug that's in development called CD839 from a company called Calithera. And they are doing a whole bunch of clinical trials in oncology, including anaplastic astrocytoma. And for patients who are getting initial therapy with temozolomide mitigation, you can go on with CD839 trial. I think I would probably do that if I had your disease. and also doing a ketogenic diet at the same time. So, you know, to go on a clinical trial means that you have to go to where that trial is being
Sure.
performed, and that creates a certain inconvenience. But I think that this glutaminolisis business is going to be a major evolution in the way we treat cancer in general. And we know that IDH1 mutated cancers are really using this particular strategy. Now, you mentioned glutamine scavenging. There's another trick that's been going on to do glutamate scavenging. So glutamate is converted to glutamate then feeds the tricarboxylic acid pathway. And glutamate, turns out there's another component of our chemistry called oxaloacetate. And if you take extra oxaloacetate, the glutamate level in your blood falls by between 40 and 60%. And so the fuel that's available for the tumor is reduced substantially.
Right.
And there's a oxaloacetate, it decomposes at room temperature, and so it's never been really available. But now there's a company that has a patent on a new anhydrous formulation that's stable at room temperature. And so they're developing oxaloacetate now for the treatment of neuroblastoma and other neurological diseases like brain trauma, stroke, anything that happens in your brain. Glutamate tends to make it worse. And lowering glutamate levels seems to be a highly therapeutic thing to do. They've tested their oxaloacetate UCSD in glioblastoma patients who are in relapse, getting other therapies, and it appears well tolerated and to produce better than expected results in small numbers of patients. In the laboratory, it adds dramatically to survival. And so I happened to be sitting next to the CEO of this company, and I said, would you consider making oxaloacetate available to my patients under the right to try legislation that came out last year? It's the one thing that the Trump administration has done that I like, is they are trying to remove the barriers to getting access to new drugs. Now, most of the time, pharmaceutical companies, they say no, because they still worry that if they give their drug to you, something happens to your patient, the FDA will get involved and delay the approval of your drug. But this is essentially such a non-toxic substance. It's already a part of our normal biochemistry. It's considered, in fact, medical food by the FDA, not a drug. And that there is really no risk to the company for doing that. So they decided that they would make this available for the asking. So if you would like, I can have this company called MetVital send you oxaloacetate for free. All you have to do is sign a consent form, which says that you know that this is, in development, not standard care. But I think it's, it's one of those things that could slow down your tumor. It could make any other therapy you take more effective, because cancer always requires energy in order to perform drug resistance or any other kind of, in order to grow itself. It's all highly energy dependent. So when we block the energy supply, it's the equivalent of, the military cutting the fuel lines to the enemy. If you don't have fuel, you can't run a plane, tank, jeeps, whatever. And so, I think it's a similar kind of thinking. And then finally, there's, you have a P53 mutation in your tumor, which traditionally has been we haven't had any drugs like that. but there is actually a new strategy of attacking a partner of P53. When P53 is missing, there's another protein called B1 that it becomes much more important in picking up the slack. And when we attack B1, we kill the cell. And so there's a drug now called darocertib, which people are really interested in. It crosses the blood-brain barrier. We already know it works actually in diseases outside the brain barrier. In fact, that crosses the blood-brain barrier has only been known for about a year. So darocertib is in clinical trials for almost a year now, and I think is something that in the future, when you're wondering what else can I do against my disease, is the kind of thing I would think about. Also, we have another class of drugs called PARP inhibitors, and because of this DNA checkpoint issue that's being suppressed by 9H1 mechanism, PARP inhibitors are also super interesting for your disease. And so I think the good news is there's a lot of new stuff on the horizon besides chemo that might be helpful. You know, these new medicines are not really cytotoxic agents. They're targeted therapies that go after one particular mechanism that we think is especially vulnerable in the tumor cell. And but on the other hand, you know, the standard therapy for you is like we consider it practically a home run for people with IDH1 mutated cancers.
Yeah, and that's what most of the expert opinions are pointing towards, that direction.
Nobody would say anything different because the data that support these statements are heavily repeated. Everybody's seen these data.
Right, whereas everything else is kind of experimental.
Right. So you won't see anybody giving you a different recommendation than temozolomide.
Oh, I figured that out.
And you know, even though I'm known as an out-of-the-box oncologist, I also basically I'm just interested in what will work for my patient.
Sure.
So I think that you might want to try and get your imagination around doing these things, and then explore the proton. Look into FET-PET, see if it's available. We can find a radiologist who will incorporate those results into the radiation treatment planning, and then you'd be getting the best kind of radiation that human beings have come up with. And you know, I think if I was in your shoes with this disease, that's what I would do.
So that's the summation. That's the executive summary report for now.
Yeah, I think, you know, that's about as much as one could say, given the current level of diagnosis that you have. But, you know, you've had a 325 gene panel in Foundation Medicine, which, in my opinion, is antiquated. They do only the copy number chromosomal changes for those genes. But we have 22,000 genes, you know, we have 1,200 tumor suppressors, 600 oncogenes. And so there's, generally, when we get these chromosome microarrays and gene expression, it's eye-opening, and it's shocking to see the other mechanisms that we hadn't thought, we hadn't imagined were operative in tumors. And so that's kind of one of my, you know, I carry the flag for this kind of analysis. And chromosome microarray, if I order it for you in the clinic, costs $2,910. But if your pathology laboratory orders it, they may get a discount, depending on what volume, because Mayo Clinic gives a volume discount to pathology labs. So if they have an account we should ask them to be the people that send it out. I can talk to your pathologist
Sure.
about this. At Cedars-Sinai, they have a 50% discount. So, it's probably definitely worth asking. And the MGMT methylation thing is super interesting. What got me interested in this is that I had a couple of patients that are off the scale. They have like 90% MGMT methylation. And essentially, your survival is many times greater than other people. And, for somebody in your situation, if you knew that now, it would give you a different feel for your immediate future.
Mm-hmm.
And on the other hand, if it comes out that you have a minimally methylated MGMT, then also that's useful information too, because you know that it's time to pull out all the plugs. And maybe that ketogenic diet is worth doing. Maybe that vitamin C expense and time investment would also be worth it.
Yeah, that makes a lot of sense.
Yeah. So.
I mean, yeah, my overall takeaway is I still have a healthy level of skepticism. I mean, especially on this stuff that's kind of theoretical. But I'm certainly interested, and I'm not, I'm open to them. I'm not saying I'm not open to any of this stuff. My gut feeling is, I want to see data, and there just really isn't any.
That's it. I mean, what we call evidence in medicine is generally a randomized clinical trial that is free of bias, that establishes beyond a doubt that something is of value. And the value may be very marginal, or it could be a major amount. For that, I would say we can only talk about temozolomide and radiation.
Right.
And because we know that treatment doesn't get us very far, the question then becomes, is there anything that anybody has learned about cancer that could improve your chance of surviving? And that's where we turn away from the clinic and into the laboratory, into the science.
Yeah.
And so the things I'm recommending, like, for example, there's another thing called metformin, which is a diabetes drug that we repurpose in cancer because it blocks a particular pathway called mTOR, which mTOR is a signal for cell proliferation and protein synthesis. So, giving metformin is kind of a nice non-toxic way of blocking that. These are what we call science-based recommendations, because it is because of the sense that whatever your survival is at 36 years of age with standard therapy is unsatisfactory.
Right.
And we got to do better than that. Maybe even get you to live long enough that somebody has a really excellent, way of cultivating immunity against this disease.
Yeah, I think that's sort of the
result in a cure one day.
Yeah, that's sort of the thought. If we, there's enough resource being poured into this thing, that maybe, in the near future there is a better therapy available. What I'm worried about is in the shorter term timeline, and this is what I'm trying to learn by talking to these other docs who have actually treated patients. What's the risk of, cognitive impairment? What's the risk of, diminished quality of life? That sort of thing. And if it's, if it's getting over a chemo treatment, I think I'm, young and virile enough to deal with that. But, the more permanent consequences of picking, the left fork in the road versus the right fork in the road right now, I'm very, aware of that.
Well, one of the questions that you should write down for the day you go and talk to a radiation oncologist is about the subject of hippocampal sparing. The hippocampus is a part of the brain that's involved in learning, memory, and like immediate recall. In fact, you can't learn anything if your hippocampus is not out. And in the, my wife in the olden days, they treat the whole brain with radiation.
Sure.
And, we got terrible cognitive results after
Right.
a year or two. People lose their memory and they get flat affect, and their interest in life goes away. By the way, if you're younger than 60, you tend not to get that, and if you're older than 60, then it's the opposite. So there's a couple of tricks. One is to, number one, not radiate the whole brain.
Right.
So just focus on the area where the disease is. And there's all kinds of sophisticated techniques with intensity modulating radiation now that has really allows the radiation oncologists to paint the dose that they want.
Sure.
Hippocampal sparing is one of the topics that's come out in the last few years. That whenever it's possible to do it, they will do it. And it really depends on the location of the tumor relative to where the hippocampus is.
Right.
Now, if the standard photon radiation is going to hit the hippocampus, to me, that's an automatic indication for protons. Because the protons go in and they stop.
Sure.
Whereas the photons go right through. And so,
yeah, and everything that I've learned about my location is actually pretty good because it's on non-dominant side and it's it's in a good spot. I had a good resection. I guess my question at that point becomes, how urgent is it? I mean, obviously for me to, even consider doing anything that would be, potentially immunocompromising, especially in the, the context of the pandemic right now, is just a really big, how urgent is this? Can we wait? And the answer that I got when I asked that question was sort of the longer you wait, the higher the dose has to be if it grows.
No, they're going to give the same dose no matter what.
Well, if it's dividing, though, it has to be bigger.
But I would say that all of the treatments that we give for cancer work better when the disease is most minimal.
Right.
And because of this phenomenon of genomic instability, the more the tumor divides, the more heterogeneity is in the tumor, and the greater the chance that you'll have radiation resistance or temozolomide resistance. And so I think that as a general principle, treating the smallest disease volume is an important principle. Of course, you don't want to take it to the point where you're treating somebody that doesn't have treatment.
Sure. But you want to get it early on. Yeah, I get that. You want to nip it
early on, and I think that this tumor has a couple of these unpleasant characteristics. For example, the Ki-67, you remember that number? 20%. That's kind of a high number.
Right.
That means that when the pathologist is looking under the microscope, 20% of the tumor is in the middle of dividing. It's kind of, not really IDH1-ish, because we think of that as a more indolent and less aggressive disease.
Right.
So normally the most aggressive part of the tumor is what gets my attention, because that's what's going to do the patient. And so, in spite of the fact that it's a pandemic, if you have a convincing MRI in the next couple of weeks that says that, hey, the tumor's back, the disease is back, I would probably say it's time for a treatment. We're going to have a pandemic for a long time.
I think so too.
A year and a half.
Yeah.
And so I think, you're just going to have to bite the bullet with glioblastoma. With temozolomide. And we'll make the best of trying to do it as safely as possible.
Right. Yeah, that makes sense.
But it is a lousy time to be a patient.
Yeah, not the most ideal situation for sure.
Getting immunosuppressive treatments.
Yeah.
Here's what I would, I think this has been I always kind of like writing IDH1 consults because I can say some positive things, and there seems like a lot to talk about in terms of therapies that are out there.
Sure.
Why don't I send you my consult? You can read it over, digest
Okay.
it, and decide if you want to make an investment into the next level of what I call the deeper dive.
Sure.
Chromosomes, gene expression, MGMT, and those things are actually more exploratory. They are in the research mode rather
Sure.
than the standard of care mode.
Sure.
So other people may not have recommended it. But certain institutions in this country, if you have a brain tumor removed, everybody gets chromosomal. So, there's a lot of variability in the level of molecular diagnosis that people recommend. And then I think, the next thing is just to see what that next study shows. If you want me to order the spectroscopy MRI with a regular MRI at Angel's Clinic, I'm happy to do that for you. Just a phone call.
Right. Yeah. I definitely need to think about that. I mean, it's definitely, it's not as easy as just going, 5 minutes down the road from where I'm at right now, but it's not, outside of the realm of, could happen.
Well, it's 2 hours, right? To come to LA.
Just about, yeah, on a good day.
Yeah, fortunately, the traffic is non-existent.
Pretty light right now. That's true. That is one positive aspect.
So I think those are the major decisions. Oxaloacetate, if you want it, you can have it. Like I said, it's non-toxic. Metformin is non-toxic. I'm willing to prescribe that for you. And by the way, if you get treated with temozolomide, you'll need your local oncologist. You wouldn't come to LA for that.
No, yeah, that I would do here. That and the radiation, unless it's the special radiation.
Right. So any competent medical oncologist should be able to supervise temozolomide.
Oh yeah, and that was always the plan. I mean, these guys here, they were not really like I said, they weren't really in the driver's seat because this is a AA case, and they don't necessarily have any specialty in that. So I'm sort of deferring to the experts to make the expert recommendations. But yeah, I mean, clearly they can follow the care plan that's laid out in front of them.
Exactly. Yeah. So that's why I was thought about sharing this with your regular Dr. Kendall.
Yeah, I mean, I haven't even really, to be honest, I haven't even really talked to him that much since this whole onset.
So who's ordering the scans then?
I mean, it's his office, but also, I'm conferring with the other, doctors at the other larger institutions to sort of hear their sounding board, feelings as to what they're seeing and what their recommendations are, and then I'm kind of, combining all those data points into decision-making choices.
Well, I think it's interesting to get, to have a team and hear what everybody thinks. I hope I said one or two things today that maybe nobody else said.
Absolutely, you did.
Yeah. So, and I'm available if you want to do this again sometime.
Yeah.
Certainly, I would like to follow your case along, and
of course,
I'll
definitely keep you in the loop.
That's if you have it done up there, send me a copy so I can see it.
Sure.
Also, the study from 3.2. I look forward to seeing that.
Right. Yeah. Yeah. Like I said, it didn't show much, but just a slightly elevated whatever on the margin. That was the notes that I got, based on the report. So nobody said, it's a smoking gun, but they definitely, everyone's kind of paying attention to that area. Maybe it was missed in the slices before, maybe it was, who knows what it was. Maybe it's scar tissue. But yeah, I mean, I don't know if you know any of these other doctors. I mean, I know it's a small community, and definitely people have their different styles.
Yeah, in general, I can tell you that neuro-oncologists are the most nihilistic and conventional people around.
Right.
They'll put you on a clinical trial if it's at their hospital and they don't do anything else.
Right.
So one of the interests I have in this field, I'm generally not, that's not the way I practice, because we have an explosion of science and new cancer biology.
Right.
Which, when you connect that with molecular diagnostics,
right.
When I go to treat a patient now, it's totally different than when I started my career 30 years ago. I know things about individuals' tumors. And by the way, as a general, I'm also a regular medical oncologist before I started doing neuro-oncology. So I've had a lot of practice with this style of medicine. I'll tell you a story that is, hot off the press from yesterday. There's a guy I treat with an AIDS-related malignancy called Kaposi sarcoma, he has chemotherapy refractory disease, he's getting immunotherapy, he's had a great response, but it's only a partial response. So I read a paper that mast cells, which cause allergic disease in the lungs and gut, mast cells infiltrate the tumor, causing immunosuppressive microenvironment. Well, in allergy medicine, we know how to target mast cells. We do it with chromalin and antihistamines. So I added chromalin and antihistamines. And in 3 weeks, this guy is having a spectacular remission. He couldn't be happier. So I sent a letter to the gal who wrote this paper telling her, and do you have any other patients where you've heard about this? She's ecstatic. In fact, she does have another patient that's had this, this great response.
That's great, yeah.
And so that's an example kind of how I practice. If I learn something new, I'm inclined to see if I can translate that into helping the patient. And so as a patient, you either want that because you don't just want to stick with the standard stuff, or some people are uncomfortable with this style of practice. They think, how what your philosophy is about your own treatment becomes a factor.
Absolutely.
Some people are they believe in science, and other people don't. The one thing you said in your self-description that caught my eye is that you like to solve problems from an engineering point of view. And I think in molecular diagnosis, when you go deep enough, you start to have a sense that you can really see exactly how the tumor is being malignant, what makes it malignant. And getting that engineering level of understanding puts me in a position to say, what can I do to block that pathway, that. And that's the kind of thing that I try to do in my clinic.
Yeah, that makes total sense to me. And yeah, I mean, my perspective is I kind of refuse to be, making decisions based on fear. And I want to be and I'd like to ultimately be making them on data, but if data is not available, then I have to sort of defer to experience and, other, indicators and other, other inference mechanisms or whatever you want to call it.
Yeah. Well, I'm in the middle of writing up a little blurb for my concierge patients. They pay me a lot of money, as you know.
Right.
And so when I learn something, I make not a press release, but kind of like a newsletter thing, which I then, I update my recommendations periodically. And so I'm in the middle of doing a niacin review. Turns out to be a huge subject in cancer. And so if you want, I can send you that, and you can, you'll be, I don't just want to be the doctor for the rich, I'd like to help other people too.
Yeah.
So as long as you don't tell everybody in the world.
Oh, for sure. Yeah. I definitely will.
Michael, still, because it takes me an enormous amount of time to do this.
Yeah. Yeah.
Actually,
I understand.
these concierge patients have created, I have 2 days a week where I just study cancer.
Wow.
And if I happen to be working on one of their consultations, that's great. But in the process, I've become a much smarter doctor.
Right.
So.
Yeah, no, I'd love to see that if you wouldn't mind.
Sure. When I get it done, I'll send it to you.
Yeah, that'd be great.
It's one of the things I'd like to see you do.
Yeah, I really appreciate, sometimes there's a little room to squeeze another person in who's not, necessarily at the high end or can afford it or whatever. So I definitely appreciate that.
Yeah.
It's a lot of learning, I'd be lying if I said, it's been an easy path, but it hasn't been particularly hard. I'm just very, being very choosy with what I do. And like I said, I kind of refuse to be, motivated by a fear-based,
Right. Well, fortunately, it's been pretty smooth sailing. So
it has. Yeah. So far, so good. It's easy to say when, it's kind of been life is normal for the most part, except for that one time where I went to the hospital. Which is.
So I hope it goes on for a while longer, and maybe some of these things like oxaloacetate and metformin could even prolong this period.
Yeah, I mean, it seems to me like those are kind of no-brainers because there's not really much downside.
Yeah, we're talking about non-toxic things.
Yeah, and even the Tipsovo, the inhibitor, has got some toxicity levels. So yeah, I mean, that seems to me like those, and that's why I'm kind of been disappointed with these other doctors, because I get the kind of don't sue me boilerplate, recommendation, which it's like nobody's kind of really ready to kind of grab their balls and actually say what's going on behind the scenes and what are the metabolic factors at play and what can you do to slow its growth and to stop it feeding itself and stop it from.
I would hesitate to give you Tipsovo now because when eventually we worry that something bad will happen with you in this disease.
Right.
And at that point, when we have the Monday morning quarterback retrospective look at what was the decision making along the way, when we have a meaningful therapy with a big survival advantage, if you didn't get it, then any doctor that was part of that, somehow supporting you and not getting the thing that everybody agrees you must get, then you become a problem doctor.
Right.
And you even become subject to lawsuits.
Right.
And so once there's consensus medicine, it's hard for any expert to disagree with you. So if you asked me to do Tipsovo after your treatment, before you relapsed, now that I would do, because you've already had the treatment, and what we're looking for is to prolong your time to relapse the next time. Because we don't want, and we have a good drug that is non-toxic. So I would be willing to step outside the box that way, but it probably wouldn't be a good idea to give you Tipsovo in lieu of getting standard therapy.
Interesting.
And imagine if you were the doctor, and I was the patient, or somebody close to you was the patient, and you have that thinking about the whole history of the disease, and what does it mean if you skip certain treatments.
Right. Yeah, that's definitely a noteworthy point for sure. Yeah, I mean, it's definitely not to be ignored that most of the other guys have recommended the kind of standard of care treatment.
Yeah, most of the time in oncology, what people refer to as the standard of care doesn't deserve that title because it isn't very good. And then basically, in my view, if the standard of care isn't curing you, why is it a standard?
Right.
But I think in brain tumor medicine, for the IDH1 mutated patients, temozolomide is a really good therapy, and so is radiation. And that's probably, no one would disagree with that.
Yeah, that's true. That is true. Yeah, I mean, that definitely seems to be the case. It's just, is there something better that's going to come along in the near future? Are we going to do some collateral damage along the way?
I can tell you one other thing, since you are, so scrupulous about this. This is a subject related to temozolomide I've been interested in for a long time. The way a drug is metabolized and handled in the population differs from one patient to the next.
Sure.
You don't get the same toxicity, right? So with TMZ, it's about 10% of people who have severe toxicity. And people have done these genome-wide studies to figure out who those people are. And there are 5 genetic polymorphisms that will tell us whether you're one of those people that's likely to get toxic. And if you knew that, then number one, you wouldn't escalate your dose. You might even think about starting at a smaller dose. Because normally what we do, if you don't fall in your blood counts on the first cycle, then the second cycle, we go from 150 per square meter to 200 per square meter. So I happen to know those polymorphisms, and if you, depending on where you get sequenced, we could even interrogate the genome for whether or not you have those.
It's worth noting to you that I'm also currently talking to the local people at the cancer center here in town about getting genetic sequencing, kind of unrelated to the AA diagnosis, but more to the Ashkenazi Jew, Eastern European Jewish heritage that is in my family history tree. More, less to do with treatment of this diagnosis, but more sort of to be aware of other potential.
Well, if you're doing this, I can tell you the best company in the world is called New Amsterdam Genomics out of Cambridge, Massachusetts.
Okay.
It's a tad expensive, $2,500, but they do all 22,000 genes.
Right.
And their portal is sort of dedicated to showing you your risk for all the diseases, not just cancer.
Right.
But for cancer, it turns out that if you look like you have hereditary breast cancer from BRCA1 or BRCA2, and we do that testing and you're negative, about one out of 3 patients that goes to New Amsterdam Genomics, they find the cause, hereditary cause, because they look at everything.
Right.
So I think if you're going to invest in that kind of thing, you might want to consider that company.
Right. Yeah. The one that they're looking at, I don't think it's that one. It's something that's possibly covered by insurance. So I think it was like an 86 panel or something like that. It wasn't. And you could choose to do the full.
Oh, you're talking about the small panels.
Yeah. And you could choose to do the whole thing, or you could choose to just look at the ones that are, for a few of the things, because you might get some gray dots in there that aren't very, like not positive nor negative.
This is really about your entire biology and your entire health, all the diseases, not just cancer.
Right. Yeah. And this one isn't specifically for cancer. Well, it is specifically for cancer, but not for the astrocytoma.
But you don't have to pull the trigger now if you're finding.
No. Yeah. There's no hurry up.
You can always do it later.
Yeah. Totally. Yeah. Well, so I just thought I'd mention that to you. That's another thing that I'd been in contact with them about. And yeah, it's on the back of my mind to consider that as well.
Okay, so why don't I send you my consult? I got some more patients to go see.
Okay, well, thanks for your time. I do appreciate it.
Good to meet you, and send me an email. Tell me what you think and what you want to do. Okay.
Yeah. Okay. That sounds really good. I'll definitely keep you in the loop, and we'll stay in contact.
Okay, Jeremy.
All right. Take care. All right. Bye.
Well.